Hello and welcome to the Jim Hook channel. I'm going to be reading to you from Joanna Moncrieff, The Bitterest Pills, The Troubling Story of Antipsychotic Drugs. I'm going to be reading a section from page 7 through to 11 on what are antipsychotics and what do they do. This expansion in the use of antipsychotic drugs has been dependent on a theoretical framework that casts psychiatric drugs as specifically targeted treatments that work by reversing or ameliorating an underlying brain abnormality or dysfunction. The nature of the abnormality is often referred to as a chemical imbalance, and drug company websites repeatedly stress the idea that psychiatric medication works by rectifying a chemical imbalance. The website for the antipsychotic Geodon, ziprasidone, an antipsychotic used in the USA but not in the UK, stated in its information about schizophrenia in 2006 that imbalances of certain chemicals in the brain are thought to lead to the symptoms of the illness. Medicine plays a key role in balancing these chemicals. My emphasis, Pfizer, 2006. Similarly, Seroquel is thought to work, said its manufacturers in 2011, by helping to regulate the balance of chemicals in the brain to help treat schizophrenia. AstraZeneca, 2011. Antidepressants like Prozac and Paxil are also said to balance your brain's chemistry. GlaxoSmithKline, 2009. And information on bipolar disorder or manic depression suggests the condition is triggered by an imbalance in some key chemicals in the brain that antipsychotics can help to adjust. Otsuka America Pharmaceutical, 2012. Information produced by professional organizations makes similar statements. The American Psychiatric Association's 1996 leaflet on schizophrenia suggested that antipsychotics drugs help bring biochemical imbalances closer to normal. American Psychiatric Association, 1996. The UK's Royal College of Psychiatrists claims that there is an imbalance in brain chemistry in people with psychosis or schizophrenia. Royal College of Psychiatrists, 2004. And antidepressants are said by the American Psychiatric Association to correct imbalances in the levels of chemicals in the brain. American Psychiatric Association, 2005. What sort of drugs antipsychotics are thought to be, and how they are understood to work in people with schizophrenia and other conditions, is fundamental to the debate about their merits and how to use them appropriately. These descriptions of the action of psychiatric drugs as reversing chemical imbalances embody a particular way of understanding the action of drugs, which I have called the diseased-centered model of drug action. The diseased-centered model can be contrasted with an alternative drug-centered model, and some of the features of the two models are outlined in Table 1.1, Moncrieff and Cohen, 2005, Moncrieff, 2008a. Table 1.1, Models of Drug Action. Disease-centered model. Drugs correct an abnormal brain state. Drug-centered model. Drugs create an abnormal brain state. Disease-centered model. Drugs as medical treatments. Drug-centered model. Drugs as psychoactive substances. Disease-centered model. The beneficial effects of drugs are derived from their effects on a presumed disease process. Drug-centered model. The drugs alter the expression of psychiatric problems through the superimposition of drug-induced effects. Disease-centered model. Example, insulin for diabetes. Drug-centered model. Example, alcohol for social anxiety. The disease-centered model of drug action is based on the idea that drugs work by acting on the aberrant biological processes, be it chemical imbalances or other abnormalities, which are assumed to produce the symptoms of a particular disorder. According to this view, drugs make the body more normal by helping to reverse an underlying disease or dysfunction. This action on the disease process is the drug's therapeutic action, and all its other actions are designated as side effects and considered to be of secondary importance. The disease-centered model is borrowed from general medicine, where most modern drugs act on the physiological pathways that produce the symptoms of a disease. Insulin treatment for diabetes helps correct the insulin deficiency that leads to the symptoms of diabetes. For example, drugs used for asthma, such as salbutamol, expand the airways, reducing the constriction that causes wheezing. Steroids and other anti-inflammatory drugs reduce the overactive inflammatory response that produces the symptoms of various conditions such as eczema and rheumatoid arthritis. None of these drugs reverses the underlying cause of the disease, but they all act on biological processes that produce particular symptoms. In this sense, the disease-centered model could be referred to as a symptom-centered model in most cases. Even clearly symptomatic treatments like the painkillers aspirin and paracetamol can be understood in this disease or symptom-centered manner, as they work by acting on the neurophysiological pathways that produce pain. The disease-centered model of drug action has become the dominant way of theorizing what drugs do when they are taken by someone with a mental health problem. It is so influential that people are not aware that there are other ways of conceptualizing how drugs affect people with mental disorders, or whether the disease-centered model is supported by scientific evidence. But the idea that psychiatric drugs work by targeting underlying biological processes that are specific to certain sorts of mental health problems or symptoms is central to the way that psychiatric treatment is administered and presented, and to the way that research on drug treatment is designed, conducted, and interpreted. The latest edition of the Principal American Textbook of Psychiatry, which, interestingly, opens with a 4-page colored spread of different drugs listed alphabetically under their trade names, stresses that mental disorders are true medical conditions that can benefit from drug therapy, in the same way that diabetes, asthma, and hypothyroidism and other chronic disorders are responsive to medication. Sussman, 2009. As you shall see in the following chapters, however, this conception of how psychiatric drugs work is relatively recent. Prior to the 1950s, the drugs that were prescribed to psychiatric patients were understood quite differently, according to what I have called the drug-centered model of drug action. This model is so named because it suggests that psychiatric drugs need to be understood first and foremost as drugs. That is, as chemical substances that alter the way the body functions. Moreover, psychiatric drugs are a special type of drug known as psychoactive drugs, which are substances that affect brain functioning and which, as a consequence, alter mental experience and behavior. According to the drug-centered model, Rather than reversing some underlying brain abnormality, psychiatric drugs themselves create an abnormal or altered state of physical and mental functioning. Psychoactive drugs, by definition, are chemicals that act on the body's central nervous system, and by doing so, produce changes in perception, mood, consciousness, and behavior. The most familiar psychoactive substances are recreational drugs like alcohol, nicotine, heroin, cannabis, and LSD. When we think of recreational drugs, we refer to the altered mental states they produce as intoxication. Some drugs, such as alcohol, produce profound and easily identifiable states of intoxication, whereas the intoxication produced by drugs like nicotine and caffeine is more subtle. Psychiatric drugs also produce states of intoxication whose features vary according to what sort of drug is taken. Just as the effects of cannabis differ from those of alcohol or heroin, so the effects produced by antipsychotics are different from those produced by drugs like Valium, which differ again from the effects of the so-called antidepressant drug, Prozac, for example. The characteristic features of the intoxicated or drug-induced state depend on the chemical structure and nature of each drug. Recreational drugs produce effects that some people find pleasurable or enjoyable. Many other psychoactive drugs, however, including the antipsychotics, produce effects that most people find unpleasant. One of the many and varied effects of antipsychotic drugs is their ability to oppose the actions of the brain chemical called dopamine by blocking certain types of dopamine receptors. At least 5 types of dopamine receptor have been identified so far, but it is the ability of antipsychotics to block one particular type of dopamine receptor, the D2 receptor, that gives rise to their characteristic neurological effects and is thought, by many, to produce their therapeutic effects. However, both the first and second generation of antipsychotic drugs come from a number of different chemical classes, and none of them act solely on dopamine receptors. Many antipsychotics, including chlorpromazine, thioridazine, clozapine, and olanzapine, have an extremely broad range of actions on a large number of the brain's chemical systems, and some of them, such as clozapine and olanzapine, have relatively weak actions on the D2 receptor. Even those drugs that target the dopamine system more precisely, like haloperidol, have a variety of actions on other systems. Despite decades of research and speculation, we do not fully understand the chemical basis of the actions of antipsychotics, or whether, as a group, they act on symptoms through the same mechanism or through a variety of different mechanisms. Although there is variation in individuals' response to all drugs, psychoactive drugs produce their characteristic range of effects in anyone who takes them, regardless of whether or not they have a psychological problem. Most psychoactive drugs also have physical effects, and the physical and mental effects are often inextricably linked. Alcohol and benzodiazepines, for example, produce a state of both physical and mental relaxation, and stimulant drugs, like amphetamines and cocaine, stimulate mental processes like attention and alertness, as well as physical processes like increasing heart rate and blood pressure. The physical and mental effects of antipsychotics are also intimately linked, as we shall see, and it is impossible to understand one without an appreciation of the other. The drug-centered model suggests that drugs can sometimes be helpful because certain drug-induced psychoactive effects can replace or suppress the manifestations of mental disorders. An example of this is the long accepted benefits of alcohol in people with social phobia or social anxiety. Alcohol is not thought to be helpful, but because it corrects a deficiency of alcohol within the brain, or because it corrects another chemical imbalance, it is thought to help because one of the characteristic features of alcohol intoxication is that it reduces social inhibitions, which may be helpful for someone who finds social situations anxiety-provoking. Following the drug-centered model of drug action, the barbiturates and other sedative drugs that were used in psychiatry prior to the advent of antipsychotics were understood to be acting as chemical restraints, which sedated people and rendered them more manageable without affecting the underlying problem. As we shall see, the antipsychotics themselves were also viewed in this manner at first. Perceptions changed over the course of the 1950s and 1960s, however, and the group of chemicals that were first known as neuroleptics or tranquilizers came to be viewed as specific treatment for the symptoms of psychosis or schizophrenia. First thought of as special sorts of sedatives, they were transformed in the minds of those who prescribed them into psychiatry's first real magic bullet.